We're going to be talking about from scan to plan, short, predictable, profitable treatment. The main goal of tonight's presentation is to make your life easier, for you to be able to approve those treatment plans from the first iteration and to feel confident approving those treatment plans. So we're going to walk you through that process. So hopefully we can clarify any questions you have tonight, but always feel free to reach out to us afterwards, to your sales rep, to us directly. We're here to answer all your questions. So as Marina said, I'm a general dentist. I graduated from the Universidad de Panama. That's where I received my DDS, and that's where I'm originally from. I completed a GPR there too, and after that, I moved to the United States and I completed an AGD residency and a fellowship at UConn. I also work as faculty for UConn for approximately 3 years. I was faculty for the anatomy and morphology course for the pre-docs, and I also was faculty for the AGD residency. I have also been in general practice for more than a decade, and I have worked in the industry as CE coordinator and medical affairs for brands like Sensodyne and Pronamo. And recently, I have been so honored to join 3D Predict as their director of scientific affairs. So when I say I'm from Panama, a lot of people have questions. They have questions about Panama. It's a very small country. We only have 4 million people. If you haven't gone to Panama, you might have some ideas about Panama Canal first, and then you might have ideas about tropical paradise. For Panama, it's much more than that. We have a booming city. In fact, Panama is well known for being the only place in the world where you can see the sunrise on the Pacific and then set on the Atlantic. And you can actually breathe clean air in Panama City because it's the only capital city that has a rainforest within the city limits. So if you haven't gone to Panama, I highly suggest you go because you're going to find a little bit of everything. So a little bit of our agenda for tonight, we're going to be talking about diagnostic materials, your prescription, which is crucial, as you know, just as you were communicating to the lab, your 3D plan submission and review, and some clinical case examples. Please, at any point, if you have questions, we're going to have allocated sections for those questions. Feel free to raise them in the chat, send them to the educational account, which is part of the meeting, or send them to Marina and she will read them out loud. So you can ask those questions, or you can wait until the end to ask them. But please ask them because we want you to feel confident after this meeting, ready to submit all those treatment plans to us and to approve them. So to begin with diagnostic materials, and I'm going to touch a little bit on this, but we all know this from dental school and from our practices. Diagnostic materials are the traditional standard of care that we're all accustomed to. Our scans, ASTL or your PVS impressions, your photos, intro and extraorals, and radiographs that may be optional. So why are radiographs optional? I'm going to touch on that in a little bit, but they are definitely optional. Where to find guidance? So before I begin, it's important that you know your doctor's account. So if you haven't been activated, it's crucial that you get activated as soon as possible so you can get familiar with all these features. But if you log into your doctor's account, you're going to find a wealth of information. We have manuals for everything from what does a good impression look like, which is very basic, to how to bond those attachments, to discuss IPR. We have videos on all of that. What are the settings for your CBCT scans if you want to submit a CBCT scans, the minimum required for those. We have all that you need under those manual section, which you're going to find in your doctor accounts right here. So right when you open it, you're going to see it. If you can't find it there, please reach out to your sales rep, reach out to us. We're going to get it for you. Also, there's some of these materials that we can give you a hard copy of. So if you want a hard copy, please reach out to your sales reps. Now, diagnostic materials, we accept all scanners. That's a question we get all the time. We accept all scanners. We can find you the guide for how to upload those STL files into our platform. So if the guide is not under the manuals, please reach out to us. We'll get you the guide. We'll get you the guidance that you need to upload those STL files. Also, as we all know, impressions, voids are not good. The problem with voids is that sometimes we get complacent. We feel that the scanner, and sometimes it can fill those voids automatically. But it becomes a guessing game at that point, correct? Is that scan really accurate where those voids fill completely? Is that going to lead to inaccuracies? Then that's going to lead to a mid-course correction. It's going to become a longer treatment plan for you, and it's going to be an aggravation to your patient. So if we can avoid these voids, and this is a very good example of what we would not want to see, and probably we will have to go back and ask you to retake that scan or that impression, please try to avoid this. Also, we want to see second molars. Second molars are important. Some doctors say, why do I need to take second molars? Well, second molars allow us to achieve ideal occlusion for your case. Even if you're not planning the stylization, which you may not be planning, it is a point of confirmation for us. So if you can get those second molars, it will be very good. As you can see, this is a great example. You can see a little bit of the retromolar pad in this scan. This is obviously not a good scan. And then finally, the occlusion. We want to see no hypercontax. As you can see here, this is a great example of a good scan. This is not a good scan. And also one point I want to bring forward is that sometimes with some scanners, for example, 3Shape and iTero, you might be taking that bite on one side and you hear that click and you think you have captured the bite, and then you submit that as an STL file. But in reality, you have captured just one side, and the other one becomes a guessing game, like I was saying before. So please just take those extra seconds to capture both sides of the bite, even if the scanner is prompting you to just submit that right from the get-go. That can save you, right, months down the line. And here is a good example of some great impressions. This is an example of one of the manuals we have under your doctor's account, like I was saying. So if you want to see some examples, they are there. And here's just a little video of a good example of an STL file. So as you can see here, this is a good impression. Now, the tricky thing is that you see here this void, right? This is still acceptable. I mean, we know perfection is rarely achievable, especially in dentistry. So minor voids like that one, they might be okay, but big voids like the ones I showed before, they're definitely gonna be a roadblock in your treatment plan. Now, pictures. So this is a quintessential example of great pictures. This is actually from the American Board of Orthodontics. As you can see, we want the extraoral pictures, we want intraoral pictures. If you have doubts of how to take these pictures, what these pictures should include within the frame, please go to your manual section. Everything is there. But I'm gonna walk you a little bit through it. So we want that picture on occlusion. The patient is helping you with that. The picture of occlusal, right? The occlusal plane should be parallel to the frame. And then we want to be able to see that posterior dentition. Also, just a little trick here is that if you are taking these pictures from your phone, which you don't need a very expensive camera to do this, then if you're logging to your doctor's account, you can upload those pictures directly from your phone right after taking them into your doctor's account. So you're not wasting any time. Also, make sure those side pictures, you are displaying the ipsilateral maxillary central incisor just a little bit, and that you can see up to the first molars. And then you're gonna take those pictures in occlusion. I mean, those occlusal pictures, I mean. And in this case, as you know, you may already know, you need to tell the patient to hold her or his breath to prevent the mirror from fogging. And as you can see, this is a very, very quick process. Actually, this video, it's roughly 25 seconds if you think. So this doesn't have to be a cumbersome process. And then the extraoral pictures, right? Teeth need to be in occlusion for these pictures. That is important. The lips need to be relaxed. Ask patients to put their hair behind their ears so they can see their neck too. And then the side picture is going to be on the same, in the same posture. Try to get the edge of that left eyelash. So you're taking the patient from the right. You want to be able to see a little bit of that left eyelash, just the tip of it. And obviously the smiling picture from the front. So both intraoral and extraoral pictures we're expecting. Why do we need intraoral pictures? I got this question a few days ago. A doctor actually asked me, well, I had this great scanner. It has great resolution. It's a color scanner, as the video I just showed you. Why do I need to take intraoral pictures too? Isn't this just a repetition? Don't you get all the information you need from my scanner? And I said, I understand some of these companies are telling you that they're replacing intraoral pictures. And that might be the case for some of your treatments. I'm not saying this not, but in reality, we have had situations where the bite looks one way in the intraoral picture, and then it looks one way in the scanner. And then it comes a point of comparison. Which one is correct? And it has gone both ways, by the way. Sometimes the doctor confirms that is the intraoral picture the one that's correct. Sometimes the doctor confirms that it's a scan that is correct. So it is a point of comparison, a point of assurance for you to know that what we're getting is exactly what's happening in your patient's mouth. So just those few minutes to take those extra records, because as we know in dentistry, sometimes actually taking more records is better than taking less records, right, for diagnostic purposes, then it's going to save you months down the line. And then a good tip to make sure you got that bite right, you know, when you get that 3D plan back, is to ask the patient to write on the articulating paper before you take the occlusal pictures. That way, everything is marked, and when you get the 3D plan back, you can compare the 3D plan, the occlusion on the 3D plan, to the occlusal contacts you have on the intraoral pictures, and then you can see that they match. So this is just, again, the same manuals that are in our website. Please go there. I'm not gonna get tired of saying it. There's a lot of information there. And now we're gonna talk about the CBCT, the optional records, the radiographs. Now, I wanna just stop here for just a second and talk about why they are optional. As you know, our AI has two parts of it, or you may not know. You may be confused because I know it's a lot to take in from the get-go. So we'd work with CBCTs for sure. If you submit a CBCT, you have it, you want to utilize it, you're using it for implants or anything else in your practice, we're more than happy to have you submit a CBCT. You're going to see the real roots and bone of your patients, movement in real time, so you can better predict those treatment outcomes. But what happens if you don't have a CBCT? If you don't have a CBCT, you're still going to benefit from the other part of our AI, because we have 14,000 cases in our database. And of those 14,000 cases, roughly 40% of those cases are root and bone cases, CBCT cases. And that AI has fed from that information from those cases. What movements are more predictable to combine with other movements, right? In what rate, at what speed? So if you don't have that CBCT, you are still going to benefit from that information. That's why these records are optional. So, but if you are going to submit a CBCT, make sure your CBCT is of diagnostic quality. Make sure the patient is still during acquisition. And also make sure you can see the crowns and full roots of your teeth up to the second molar, because that's going to allow us to give you the whole anatomy of your patient in that 3D plan. Now, this is just a little video of how to export CBCTs into your patient submission. So you complete the fields, the patient's name, you mark as a deep CBCT case, and then in this field, you're going to upload the CBCT file. Now, it is important when you're going to upload that file, you're going to obviously find it in your computer. You need to compress it or zip it, right? You're going to have a lot of DICOM files in there, hundreds of them. We need a compressed file. It's going to take a few minutes to compress. After the file has compressed, the only thing you need to do is drop it into our platform in that field, and it's going to upload. So it's very user-friendly. And there's even in our manual section, a CT file checklist. It's going to tell you the minimum requirements for file setting, physical size, scan resolution, etc. So there's, preferred requirements, but there's also minimum requirements. So if you have questions about it, please check our manual section. Everything is there, or ask your sales rep to give you a hard copy. Once again, CBCT is not required, it's not needed because we have the AI. Do you have any questions at this point on records?
Sophia, thank you so much. There is one question from Dr. Perez. Give some camera recommendations, brand and mobile. So you can use, I just can answer it. You can use your professional camera, any professional camera, or you can use your phone, iPhone or Android. So what we need, because modern iPhone, modern smartphones, they have very good camera. So what we need, we just need a very good photos, high quality photos. We want to know the gum, whereas if the patient has a gummy smile, where is the midline? So we could plan a really good aesthetics for the patient, not only straight teeth, not only proper bite, but also aesthetics. So we will never do extrusion of incisors if patient has a gummy smile. So the short answer to your question, you can use any modern smartphone, or if you use camera, professional camera, please use any. We just need good quality photos.
Correct. Yes. Any other questions?
There is a question from Dr. Silvoy. Is there an option for trimline output and base modification for in-house manufacture? So if you do in-house manufacturing of aligners, if you do 3D printing, we can send you STL models, which you can use for manufacturing. And so then it's up. We usually provide a straight trimline for aligner manufacturing. And if you want a low base, we can cut the base so you can spend less material for 3D printing.
Anything else?
No, there were no other questions. That's it.
Okay, perfect. Thank you for your questions. So now we start the fun part, the prescription. How do you find your treatment goals to get those treatment plans approved from the first version? So we all know that we need to define our treatment goals for everything else we do in dentistry. I think sometimes with aligners, we get focused on aligning teeth, making everything perfect. Class 1 molar, class 1 canine, midline straight, right onto the face. But sometimes that doesn't really match what the patient is looking for or what will be ideal time-wise. So those things are important to keep in mind and to train your staff on too, because sometimes your staff fills up the prescription to what is ideal, and without having a conversation with you first. So you're going to see some examples that are going to clarify what I'm saying right now. But let me start with saying that you start completing that prescription even before you see your first patient. Right from the moment you get activated, you should go to your clinical preferences, which is, again, in your doctor's account under your profile. So if you create profile, you're going to open the clinical preferences. This is going to save you a lot of time. If you complete some of these clinical preferences, and what this means is that you want this applied to all of your cases from then on. So some doctors, for example, if you see here what dental notation you want, you're going to pick universal, most likely. Do you want IPR from the first appointment, or you want to start IPR later on? It depends on your clinical preferences. Some doctors want to start IPR from the first appointment because that appointment is usually longer and they want to get it out of the way. Some doctors prefer to do it later on. So it's completely up to you. If you want to leave this field blank, you can definitely do it. But if you know that for every single case you want to do your IPR from the first appointment, then you don't have to repeat yourself every single time. Also, attachments. Do you want to place them from the first appointment? Do you want to wait until the third appointment? And a word on attachments right now is because we get a lot of questions on attachments. Is sometimes it's better to place attachments on the third appointment instead of the first appointment. Some of those cases will be, for example, patients that have issues with manual dexterity. Patients that have some underlying diagnosis like Parkinson's disease, for example. Patients that are a little older, they might have issues with the path of insertion, and removal of those aligners from the get-go. They might need some time to get used to the aligners before you add those attachments, right? So you might want to wait a little longer to place those attachments. Also, patients with long crowns, they may have issues removing aligners. So you also want to wait to add those attachments under the third step to allow them to get used to them. And also patients with gingival recession, right? Patients with gingival recession, we know they might be a little sensitive per se. You want to start some sensitivity treatment. Put them on some anti-sensitivity mouthwash, for example, before you even get to that stage. Also, if you give them time to adjust, the sensitivity might be less than if you add those attachments from the get-go and create more retention, right? So more issues for you. Just know that with patients with gingival recession, just because of dentin exposure, correct, you might have some sensitivity regardless. So you might want to talk to your patients about expectations. So expansion, some doctors want to complete this field or not. I don't find it as a general dentist that is crucial for you to tell us if you want to do expansion on every single case or not. But I feel like at least attachments and IPR, it is important. Now, incisor relationship and overcorrections is the same thing as expansion. I don't think as GPs, we might get into too in-depth on it. But additional notes, I want to have a word on this. It is important. So RAI keeps everything, or try to keep everything inside of the anatomical boundaries of the patient. We also try to marry that with the 6 keys of occlusion from Andrews. With that being said, if your main priority is keeping those roots inside of the bone within the alveolar housing, please write us a note. This is actually a real note from a doctor where he's saying attempt to keep roots within the alveolar housing every single time. He's telling us his main priority over Andrew's 6 keys of occlusion, over molar class 1, canine class 1, and anything else in between is keeping those roots within anatomical boundaries. So we already know where his mind is even before he's submitting any patients. So if this is where your mind is too, I highly suggest you complete this too. So this is an example of a patient and how writing the prescription with your treatment goals in mind from the get-go can save you some time. So this patient came to the practice. Her main concern was, her chief complaint was, I want to fix my crowded teeth. This patient, as you can see, had crowding upper and lower on the anterior section. The patient had some gingival recession too. She actually had a nice profile, and she had malocclusion class 1 bilateral. You can see she's class 1 molar on both sides. This is a prescription we got from the doctor. Doctor said maintain over Vi and over Jet because there was really no issue with it. Please maintain midline, which is up to her upper midline. And then canine relationship, molar relationship, class 1 bilateral. Finally, she let us know that she wanted to treat both arches, expand the maxilla and the mandible, and align teeth to the gingival margin. And her diagnosis was anterior teeth crowding, which was the patient's main complaint. Now, when the doctor went to review the treatment plan, right, and you can see this is our bone module. You can see here, this is basically telling you the width of the bone. Green means you have more width, right? And red is a little less width. Everything looked good. There was no major, bone recession after treatment, maybe just a little bit on upper lingual, but nothing that the provider deemed unacceptable. Also, when she went to see the alignment of the teeth on the crown module, she noticed that the occlusion was up to her standards and what she thought it was acceptable at the end of treatment, what she had in mind. There were no drastic rotations of teeth. Everything looked good. Arch forms look good, upper and lower. And obviously in here, we can see that then she used the grid, and every square here on the grid is 1 millimeter. And in here, there was an issue that she noticed right away. Number 8 has an incisal discrepancy related to number 9 of almost 1 millimeter. So this was an issue for her. Obviously, it was an issue for the patient who was very aesthetically oriented and didn't want this. So the patient had to go back to the technician and say, this is not an acceptable treatment plan. This is not aesthetic. So what happened here? And this is the second treatment plan that the doctor got. And this was actually up to her standards. As you can see, and you're going to see it later on in the video, everything else check out just as I explained it before. And also the discrepancy was gone, so the teeth were aligned to the incisal margin. What happened here is that the doctor check or the staff check align teeth to the gingival margin instead of the incisal edge. And this is what caused that discrepancy and that miscommunication with the technician. So knowing that the patient wanted those teeth and there was not going to be any enameloplasty later on or any restorations done on those teeth, then they should have been aligned to the incisal edge. The doctor could have saved 2 or 3 back and forths with the technicians if this box would have been checked from the beginning. So this is just to say that attention to detail and to every box, it's important. If these are your treatment goals, it's important to define. And this is specifically is a very important treatment goal, knowing does your patient have a gummy smile, then I might want to align those teeth to the gingival margin. But if the patient doesn't, the incisal edge is usually the way to go. Now, talking about your prescription on the 3D plan, it's important to read the prescription. If it checks, has the prescription being followed? It checks all these boxes. You're going to see your treatment plan. The technicians usually leave you comments on the treatment plan telling you, doctor, you ask us to rotate this tooth this much, or you ask us to close this gap this much. We were not able to do this movement is outside of the predictability or so on. Or the teeth are going outside of the root. The roots are going outside of the bone. Please take a look at it. Is this acceptable to you? Please just read all the comments from the technicians and know that this is just normal. It's expected because technicians are just bringing attention to you to some areas that just may not be possible to achieve based on your patient's anatomical boundaries. There may also be requesting some clarification, correct? So this is some examples, real examples from some of our technicians' comments. They might be able to tell you this is not possible, what this is requesting to fully achieve Andrew's 6 keys of occlusion based on this patient. Please know that this movement that needs to be achieved with class 1 could not be done because the third molars are there. Where the third molars going to be extracted, maybe you're going to extract them. That's important for us to know. If you're going to extract those third molars after the treatment, before the treatment, those things, that may slip our minds at the beginning, it's important to keep a tab on those. Also, please know that extrusion of this tooth increases the recession, the bone recession. Please let us know if you want to continue with this treatment. They may check on you. And also, if you didn't put this on your clinical preferences in your doctor's account, you might get a lot of this. Please know that this increases the roots going outside of the bone. So once again, complete your clinical preferences. Make sure you check all these comments from our technicians and know that we are only trying to get the best treatment plan from you, but we are going to follow your prescription to the T as much as possible. So good prescription examples now. This is a great prescription example. The doctor is telling us what type of occlusion the patient has, right? What they're trying to get. And this is after we check all the boxes, right? Because there's a whole prescription where you just check boxes and you tell us, as you saw before, the type of occlusion you want, if you want, what type of canine relationship you want, what if you want to treat both arches, expand or not expand. After you have completed all this, there's a field that you're going to give us additional comments and you're going to give us a diagnosis. And this is where you can give us all that extra information or clarify anything you feel you need to clarify. So for example, in here, the doctor is telling us, please improve improve the midline by this much, which is great. And then make a space for implant number 19 to equal the width of 30. So this is great because sometimes we get prescriptions that say, please make a space implant, number 4. And that's okay. And we can definitely do it. But do you need a specific millimeters? Having those measurements there, it's key. You know, you are the doctor, you know exactly how much with the width of that crown, and it will help us a lot to know it too, so we know the type of movements to get you there. This is another example for implants. Patient is missing number 4, it will be replaced by an implant. Please upright number 5. The doctor is telling us how to get there to make that space, and then they're telling us the width of the crown is going to be 7 millimeters. So now we know how much you need to get there. And like I said, you have the diagnosis, the clinical condition, and the comments. So this was one doctor writing all this information. She gave us the chief complaint, the crowding, the rotation of the canines. Patient doesn't like the concave appearance of 8 and 9 because there's a slight mesial rotation. Patient wishes to have completely aligned and straight anterior teeth. She had ortho relapse. Please expand 2 millimeters and avoid IPR in the beginning. She's telling us right away that she doesn't want IPR in the beginning until interproximal surfaces are aligned. And please start the attachments at stage 3. This is giving us a lot of information that just writing this, taking 1 minute to write this or 2 minutes to write this, can save you weeks of going back and forth with the technicians. And this is one final good example. This doctor is telling us patient wants to improve anterior superior teeth because they had ortho relapse. They want to keep their molar teeth in place. So whatever the occlusion was probably wasn't ideal based on this because the bite is stable. They are only caring about the anterior maxillary teeth being aligned. In that case, we understand we're not going to be moving posterior teeth. We're just going to be fixing the crowding that the patient has. So any questions till this point? I think we do have. I see seven chats already.
Yes, so I see Dr. Stephen Rosentine wanted to ask a question. Dr. Rosentine, could you please type your question into the chat because we cannot unmute you. And so there is one question. Can we treat patients without attachments at all?
I mean, most, we do complicated treatments, right? And we do simple treatments too. You might be able to do some movements without attachments, but for most of the movements we do, you're gonna need attachments. And attachments, just a word on attachments. Attachments don't need to be complicated. We only have 5 shapes, and of those 5 shapes, we mostly use 4. And they are either rectangular or triangular attachments. And we can walk you through the whole bonding the attachments, making sure they are there, how to polish them, and so on. We have guides on all that. So it doesn't have to be this complicated process for you to get there. But if you want to treat, patients with crowding, you're definitely going to need attachments.
Yeah, thank you, Sophia. I just want to comment on that there are certain amount of movements and there are very limited amount of movements which could be achieved without attachments. First of all, and second, for example, if patients have short clinical crowns and some adult patients, they have really short clinical crowns, we have attachments for retention, not for tooth movements. So just answering your question, very limited type of patients could be treated without attachments at all. So we don't want you to limit amount of patients you are going to treat. We want you to help all of your patients to move teeth for all patients you want to place implants or just align them their teeth. And as Sophia mentioned, we can have we can plan simple tooth movements, but still, in order to achieve your treatment goals, in order to move teeth, for majority of cases you will need attachments. If you compare to other teeth systems, you will need less attachments with 3D Predict, just because we have our AI protocols and we know we put attachments only when they're needed. But just to answer the question, in order to have predictable treatment, you will probably need attachments. But if you don't want to put any attachments on the patient, please type it in the comment in your description, and then we'll only plan those types of tooth movements which could be predictably achievable without attachments, because we don't want you to have refinements. We want you to treat your patients predictably without refinements, like in 6 appointments. So this will allow you to get really good clinical outcomes and with less chair time. And if you have less chair time, you will have higher margin when you treat your patients. And I just wanted to reiterate on this. All of 3D plans are reviewed by orthodontists on our side. So if you don't want attachments, you can be confident that our orthodontist will review it and you will get only 3D plan, which could be really predictable without attachments, or that your 3D plan, which you will get, it has simple and predictable tooth movements, with attachments or without, but you could be confident that you will get a predictable 3D plan. So I do not see any other questions in the chat.
Perfect.
Yeah, that's it, yeah.
So 3D plan submission and review. So how to make that treatment plan submission and how to check it so you can approve it right from the get-go. Make sure it aligns with your treatment goals. Make sure you know what you're looking at. So like Marina was saying, you can feel confident right from the get-go that all of your treatment plans are reviewed by an orthodontist. Furthermore, not only all your treatment plans are reviewed by an orthodontist, but if you have any questions at any point, even before submission, after submission, during your treatment, about what's happening with your treatment, if you want to know more about the movements that we're making, why we decided to add the attachments, why we decided to add the IPR, where your treatment is going, please get an appointment with our clinical expert. He's an in-house orthodontist. So you go to your doctor account, you go to contact clinical expert, and you can get a Zoom appointment or even just a phone call, whatever works best for you. We are here to support you every step of the way. Also, even before you submit that treatment plan, I highly suggest you organize your records. Put all those files into one folder. So you have all those pictures, STLs, DICOM, if you're going to submit it in one place. So you can submit it right away. So this is just how you will submit a treatment plan. You are going to go to your doctor's account, click submit patient, input your diagnosis, obviously the patient's name, right? And then you can either minimize that folder where you have all those files or split your screen. And then the only thing you need to do is drag and drop. You're going to drag and drop your STL files where it says STL files, your CT files, which are DICOM in the CT files, and then all your pictures where it tells you based on the icons. It's very user-friendly, as you can see. And then at the end of all that, you just complete the rest of your prescription. As you can see, you only have to check boxes. Some of examples, you want to treat both arches, like I said, the occlusion, the canine relationship, etc., etc. And at the end of it, the only thing you need to do is click submit. Now you see this field here, and I want to touch a little bit on that in the next slide. This is another question that we get a lot. Sometimes when doctors are submitting, they don't either complete this portion or they don't complete it completely because it may be your staff submitting your patients. This is crucial. We need to know if you have bridges, if there are ankylosed teeth, if there's implants, facial restorations, crowns, veneers. Why? Because if you have any of those, we can't place attachments of those. Placing attachment of those might make you have to change that restoration at the end of treatment, might damage that restoration. Either if it's a crown, it doesn't matter, you might have to replace it. So sometimes you're thinking about it already from the get-go, I'm gonna replace this restoration. So if that's the case, by all means, we can place an attachment. But if you're not thinking about replacing that crown over that implant, please let us know so we can avoid that pain of going back and forth about the attachment if we need to change the treatment plan. Sometimes doctors have gotten even trays and they have come back to us and tell us, oh, I forgot to mark that there was a crown here. What am I supposed to do? And sometimes we can work with it and sometimes we need a full set of new trays. So please make sure you pay attention to this area and you let us know where are those restorations, those prosthetics, and also if you're planning to extract any teeth because that's going to help with the movements. Some teeth we might not need to move if we already know that you're planning to extract them, and that make your treatment plan shorter. Now, steps in reviewing your treatment plan. you're gonna go to the bone module. You're gonna review the occlusion, evaluate your overjet and your overbite. You're gonna check upper alignment and lower alignment and the path of movements. And I'm gonna walk you through that, and then we're gonna see an example at the end. So the bone overlay. When you're looking at the bone overlay, which is the little icon you see on the lower right here, is you're gonna look at your roots. You're gonna look at your bone. Is there any recession you don't feel comfortable with? Does it look like, the bone is too thin up to your standards? Please check lingual too, because sometimes it's easy to overlook it. So this is the bone module, and that's why it's important. After that, you're gonna go back to your crown module and you're gonna check occlusion. Is occlusion up to your standards, what you were thinking about? Are there any hypercontacts, correct? You're gonna check your molar relationship, your canine relationship. Does everything look good to you? And then the overbite and overjet. And in this case, you can zoom in so you can see that very clearly. And then obviously you can see this case looks very good. And please check it from the lingual too to make sure the overbite looks good. And then the upper alignment, in this case, the grid comes very handy. Like I said, every square is 1 millimeter. So you can see, especially on the anterior section, do you like how those teeth are aligned? Is 8 and 9 at the same level if you were thinking about aligning into the incisal edge? Are there any rotations that you are not happy with on the lower and the upper? And then the path of movement, you go back to your bone module and to check how does the path of movement look. Is there too much round tripping? And for those who are not familiar with round tripping, which I wasn't familiar with that terminology before I started learning about aligners, is when you actually push those teeth out because you have, for example, carotid, to align them and then push them back in. So when you push them out, they are in an unhealthy position, and then you are putting them back into the bone a little bit. Sometimes that can happen. Round tripping is normal to some extent, and sometimes it's needed and unavoidable. But if it's too much for you, for your standards, then let us know and we can work with you. Is IPR feasible? Sometimes teeth are rotated and you can get to that interproximal contact to make that IPR happen. You want to make sure that at each step that you have to make that IPR, whatever that is, you can actually get it done. Will I need elastics? Obviously, you might not want to use elastics. We'll let you know if those movements will need elastics. As you know, we can make a lot of movements up to 3 millimeters, distalization, which you might not do without any additional attachments, including elastics. But if you do need them at some point, we'll let you know. So this is a clinical case, a real life application of what I just mentioned. This is a very interesting case. I really like it. So this patient came to the practice. Her chief complaint was, my wisdom teeth caused my teeth to shift after I finished my ortho treatment, and I also lost my retainers. So she had mild relapse and also deepening of her bite. As you can see, she is class 1 on the right, class 2 on the left. That didn't really bother her, and she had mild crowding on the lower and on the upper. So this was the initial prescription from the provider. It was a deep CBCT case. He said to please maintain the arch form, obviously decrease the overbite to correct that deep bite that the patient had, ideal kind of relationship, ideal molar relationship. And this was the prescription, previous ortho with mild relapse. And align the midline. And then if we look at this patient again, you're going to notice that the midline, the upper midline is onto her face, but the lower midline is towards the left. And this because this patient has a mandibular asymmetry, making her lower midline shift to the left. And that changes the treatment plan completely, as you're gonna notice right now. The provider didn't let us know about it when he first submitted the treatment plan, and this is what he got as the treatment plan. So this is the crown module, which is the first view you're gonna get when you open your treatment plan. And this is how the patient looked before. And as you can see, there was distalization that happened on the upper to create that midline, to make the upper and lower midline align. So the lower midline stayed the same. It was the upper midline that got shifted to the left. And right now you might be thinking already, well, but wasn't the patient midline, the upper midline, onto her face, and her lower midline was the one that was shifted to the left? And that's exactly the case. So this was a problem right from the get-go, because now we are creating even a bigger problem for the patient, because this this correlates to a real patient, to a face, right? And our technician was just following the doctor's prescription, which was align the midline. And that's exactly what the technician did. The doctor didn't specify align to the upper midline, and that was the problem. So it looked great, right? You can see class 1 molar, class 1 canine, and you can see the upper and lower midline coincided perfectly, but it really wasn't a good treatment plan, because if we were going to align that midline based on the lower midline, we were going to create a bigger issue for the patient, aesthetically speaking. So the provider noticed that, and then he wrote a new prescription, which was very similar to the first prescription. The only thing that he changed is, I don't want the canine relationship on the left to be corrected. I don't want the molar relationship to be corrected. The bite is stable. And also, I don't want that midline to be corrected, because the upper midline is onto her face. And another reason why the provider decided to do this is because the patient was going to move in 6 months. And the original treatment plan was 31 trays. And the provider had promised the patient that the treatment was going to take less than 6 months. So correcting that molar relationship, correcting that canine relationship, correcting that midline, that the lower midline to coincide with the upper midline, was going to take more than 6 months. And that's not really what the patient wanted. The patient didn't care about the molar relationship, which she was happy with her bite where she was. She had no TMJ issues, so she just wanted the crowding resolved. So this was the new diagnosis, clinical condition, the new prescription. The doctor told us what the issue was, and then he let us know the upper midline is on, lower midline is off, right? And please don't fully correct it and leave N on class 2. And this is exactly what the doctor got. As you can see, class 1 molar on the right, we didn't touch the molar, the class 1, the class 2 on the left, and we left the upper midline untouched too. And this was the review of the treatment plan. As you can see, it's the same steps that I gave you. We went to the bone overlay. This was the final treatment plan for this patient, the one that got approved. Everything looked good. No recessions that were deemed unacceptable by the provider. He checked the bone width too. It looked very good. And then as you can see, the progression of the treatment plan, exactly what he asked for. We didn't touch the molar relationship or the midline. We just corrected the crowding. The occlusal contacts were exactly what he thought they were going to be at the end of treatment. The overbite and overjet look very good. The same from the lingual. And then finally, he went to the grid and he saw that everything was aligned as he had requested. The same for the lower. And then obviously at the end, he decided to check the paths of movements, right? Which you can see here. Not too much round tripping. In fact, no, zero round tripping because we were actually retroclining those teeth. You can see even more green, which means there was more width of bone on buccal. But you always want to check to make sure there's nothing that is not sitting well with you. And that's the treatment plan that got approved. So if the provider would have let us know, if the provider would have sat with the patient and defined those treatment goals from the get-go, they could have said some back and forths with the technicians. But the patient was very happy with her treatment. This is a treatment plan completed. As you can see, she completed this in November. You can see class 1, class 2, the crowding has been resolved. If we compare the last pictures of the patient with our projection in the treatment plan of what she was going to look like, this tracked beautifully. She was very happy. The treatment plan was completed in approximately 5 months, so not even 6. And also you can see the before and after for this patient. The crowding was completely resolved. And I want to bring your attention here to tooth number 26, because we did take a CBCT. As you remember, this was a deep CBCT case. We took a CBCT after treatment. And this is going to bring the importance of CBCT cases, because especially for ortho relapse, where there has been movement previously and you don't know where that bone is because it has been manipulated, you may want to take a CBCT. Because if you look at tooth number 26, at the beginning of treatment, you see this thin bone phenotype of this patient. Any movement that was not a control movement that would have happened here could have taken this tooth outside of the alveolar housing, caused recession for this very young patient that she was going to probably see in 5 years or so. If you can see, we made the exact amount of movement because we knew where we were, and you can see the bone still in there. So that is a very clear example of why this is so important. And these are her extra old pictures. You can even see in her serious pictures still smirking a little bit compared to her initial picture. She was ecstatic with her results. Also, if you take a look at her mandibular symmetry, you can barely notice it on her final pictures, which is something that we didn't expect. So as a summary, please take accurate diagnostic materials. Like I said, a few minutes can save you months down the line. A clear prescription allows you to approve treatment plans from the get-go, so our technicians can know exactly what you want and what your patient wants. If you have any questions, read our manuals, reach out to us, reach out to your sales reps. We are all here to help you. And please complete your clinical preference section if you want some preferences applied to all of your cases.